motion to approve?
I'll move to approve.
Almond moves, seconded by
I'll second it.
Berg, seconds. Discussion. Hearing none, all in favor, please say aye.
Aye.
Pose same sign, motion carried. Allowance on the bills, approval of the bills, questions or comments? Is there a motion?
I'll move to pay the bills.
Nissen moves, I'll second the motion. Discussion. Hearing none, all in favor, please say aye.
Aye.
Pose same sign, motion carried. Now, no warrants. And at this point, Corinne, if you would please introduce our guests and invite them forward. Thank you.
I think what we're going to start with is the contract.
Okay.
And the contract that I have before you today is our contract to continue to substance use assessments with Project Turnabout. When I was here in December, January, I don't remember which time it was, we had decided, as you guys are aware, we contract with Divine Hope, Project Turnabout in Woodland Centers to do our chemical use assessments. With Project Turnabout, we have always done a set amount for the year, so that assures us slots on the calendar, assures us their staff time to be able to complete our assessments. What we started the year out with is because of changes with the what's direct access, which is part of our reform, which I'll be talking about in a little bit. Our hope was that the direct access in which providers are going to be able to bill out medical assistance for the assessments versus the county for those assessments. Our hope was that was going to be up and running. It's supposed to be up and running in 2018, and it is thus not ready yet. So we had initially started the year with Project Turnabout to do a half of a year contract to kind of get us through to direct access. Well, we are here and we do not have direct access yet. So what we're doing for the second half of the year is, because of the number of assessments that were done in the first part of the year, we are decreasing the amount to the 12,000 down to 6,437 for the second half. So that would be an assured amount that we're giving Project Turnabout to be able to continue to do our Rule 25 assessments. But in agreement with them, we decreased that amount in half. Again, with the hope that direct access will be coming, and also that once direct access does come, then we could work towards discontinuing the contract. But for at least now, we've decreased it to the 6,437. So that's the contract that I have before you today.
Any questions for Corinne?
Is there a set number of assessments? Is that how you arrive at that dollar amount?
Yeah, and what that looks like is they need to assure us 2 to 3 assessments a week that they're doing.
Okay.
So that averages out to about $136 on an assessment, $136 an assessment.
And they do that in Wilmer here?
Yes, most of them are done here in Wilmer. Okay. Yep. And they also do, like, they'll go to jail. All of our contracts, they'll go to jail if they need to go to jail, those sort of things. But majority of them are done at their office here in town.
Mr. Chair, I would move on the contract.
I have a motion to accept the contract. Is there a second?
I'll second that.
Seconded, Mr. Almond. Discussion? All in favor will say aye.
Aye.
Pose same sign. Motion hereby carried. Thank you,
All right.
Corinne.
The next thing up is that our annual report on the substance use disorder program. And I do have staff here, as we have had in the past. And I would like to introduce them and have them tell you how many years they have been here with the county. And we have, these ones are long-termers. We have Virginia.
I'd say they are.
I've been here for 28 years, 29 in October. Long time.
And Andrea Mossberg.
Hi, I've been here 32 years.
Oh, my.
Virginia is our social worker who is assigned to our our substance use program. Andrea is our case aide who does support work for a variety of programs on waiver adult mental health, but also the chemical dependency. So as we move forward on the annual report, as you look at the sections in your annual report, as you'll see when we look at our substance use assessments or our referrals, remind you that what we're required to do is we're required to do assessments. It's called Rule 25 assessments, and those assessments are for people who don't have any funding or are on medical assistance. Those are our responsibility to be providing assessments for. We also have provided assessments for some people who are on managed care, and then the providers are billing out the managed care versus billing us on that. And as you'll see in the annual report, we continue to see the decrease in the number of chemical use assessments or substance use assessments that we are providing. That is an expected trend because of the increase in the number of people who are getting on insurance or an increase in the number of people who are on managed care. So we anticipate that obviously will continue to, hopefully will continue to decrease. And as we move towards direct access, as I'll talk about here a little bit, that will eventually go away. Rule 25s, as we know it today, will go away by July of 2020. So we obviously, as I said, we see that trend and are anticipating that trend will continue to be happening. As I said, we continue to contract with Divine Hope, Project Turnabout, and Woodland Centers to be able to provide our substance use assessments. What that means is that, to back up a little bit, just to remind you that we work with corrections in our chemical use assessments, in our substance use program. And so corrections, as well as us, are utilizing on the calendar, we call it, with our providers to be able to do these assessments. So it's not just family services alone, it's also corrections. And those contracts that we have is we have a shared calendar in which we, between corrections and ourselves, we put people on the calendar to be able to get those assessments completed. And that rotates based on who has open appointments, open slots on the calendar. Our people, as well as corrections program, is setting those appointments up and getting people referred and being able to get their assessments done. If you, out of the 303, about 2/3 of those are corrections referrals, and the other third being health and human services referrals. Majority of corrections obviously are coming out of a court-ordered situation based on whatever criminal situation they may be involved in. As far as family services, some are through the child protection system, in which they've been either voluntarily or court-ordered to complete a substance use assessment. And we also have what's called pretrial assessments, where maybe it's someone who's at jail, they haven't gone to trial yet, but they're wanting to do an assessment before they get to that situation. Those are family services' responsibility to set those up as well. And then any voluntary. Anyone who needs to come in and is asking for an assessment, that's our responsibility to set up, again, based on their income eligibility and what their funding source, or in reality, what their funding source isn't. So, like I say, majority of those are corrections and the rest are health and human services referrals. If you look out, again, we're looking at that 303. Out of those 303, 108 of those, the outcome or recommendations were for non-residential treatment. 99 were recommended for residential treatment. And then the remaining had a variety of different recommendations. It might be educational, an AA or NA, abstain and test. Those would be some of the other recommendations that came out of assessment. But the majority would be the non-residential treatment. In 2018, we found a real struggle with being able to get people into beds for residential care. We found that, and that would be something that was found across the state, not just unique to Candioi County. That bed capacity was a major issue in 2018, and in reality continues to be. We're seeing a little bit of a positive change in that as we're into 2019, but finding that residential beds was a struggle and continues to be. Another thing in 2018 that we found is the wait time for outpatient. That wait time increased in 2018, and that had been a change for us. And again, we see we're still struggling, there's still some wait times with that as far as in 2019, and we're anticipating that's going to be an issue that's going to continue due to some of the reform things, and I'll talk about that a little bit in the future here. And when you look at the identified drug of choice at assessments, now this is at the initial assessment, what the client is identifying as their drug of choice. And some of these, the numbers are going to seem weird, but it's because people may identify more than one drug of choice. 222 identified alcohol as their drug of choice. 170 identified meth, 162 marijuana, and so those were our highest numbers of the type of drugs or alcohol that the people were identifying as their primary use. And again, someone may identify one type, some may identify 2 or 3 types. But these are just some of the hard numbers as it relates to the assessments that we've completed. And again, those are at assessment. They may go to treatment and they may look at identifying other primary sources of their drug usage, but these are at assessment. If you look on the second page, I just wanted to kind of update you a little. On the column, on the green column, I believe you guys have the color, on the green column, those numbers that are on the green column are 2017 numbers. So I'll give you just a little bit of numbers as it relates to 18. At the time of the report, the 2018 ones weren't available. They just become available. And when we look at these numbers, you have to remember that these are numbers for all of Kansas County. These are not just for the assessments that we were involved in or the treatment programming that we were involved in. And our numbers stay fairly consistent in 2018 as they were in 17. And as far as admissions into a treatment program that were non-residential, we were at 51 in 17, we're at 53 in 2018. Long-term residential was at 25.1 in 17, 25.5 in 18. 20% in 18 for the short term versus the 22 that it was in 17. And of those admissions, 66% were male in 2017. It was 65 in 2018. 33 were female in 17, and 34% were female in 2018. And between the ages, again, those stayed consistent. 39% of the 25 to 35-year-olds. In 2018, it was 36%. In the ages 18 to 25, it was 23 in 17, 20% in 18. So we see a real consistency in those numbers from 17 to 18. And again, those are for all Kansas County residents that went into treatment or were involved in a treatment program. Those are those numbers, not just ours. Those come from the DANS report. The DANS report is anyone who, treatment providers are required to report into DANS about anyone who comes into their programs. And so a DANS report is about a 77-page report that talks about all of Minnesota. It talks about what type of treatment, where the treatment was, all of those sort of things, and they break down per county as well. And so if anyone is interested in that report, I can make that available to you. But like I say, it's about a 77-page report that really looks at treatment across the state and what are some of the facts of the treatment programming. So that is kind of the annual report that I have as it relates to substance use disorder program. I don't know if you have any particular questions before I move into talking about reform.
Questions?
Yeah,
Corky?
funding for the inpatient treatment, residential treatment. Years ago, there was state-provided, the counties was funding, and that would vary from year to year. Is that a similar program for those people who don't have the income for treatment?
Right. The people that, we have the Rule 25, which is the assessment piece that's done for those who do not have any funding source are on MA. And then the funding program is what they call Rule 24. And that Rule 24 is consolidated treatment funds. And so someone who doesn't have on any funding source or on MA, we connect them with that funding.
Okay.
That funding is provided to the providers to be able to have them enrolled in their treatment programs.
Okay. I'd be kind of curious, many years ago, the Consolidated Treatment Fund, part of the funding was really based on compliance checks, local compliance checks, and influence how much the counties would get in their funds. And I was wondering if they still have a formula like that, because it's really important, and that's kind of changing the subject, but when there are compliance checks, that it can, all this different stuff can affect something else you don't even think about.
I've never heard compliance checks sort of thing, and again, I mean,
Yeah. Well, it's two separate.
Yeah, and we have a percentage that we are, the county's responsible for 22% of the cost of people going into treatment. And so that is a bill that we receive as we move forward throughout the year. That 22% is what we're required, our responsibility in that. As we move forward into reform, one of the hopes, obviously, is that medical assistance, who are on medical assistance, the providers are going to be able to bill out for that. And so our amount of percentage that we're going to need to be paying will be decreasing, hopefully, is the hope in that as we move forward.
Great.
Again, I haven't heard the compliance. That's interesting.
It just kind of popped in my mind. I don't-
Yeah.
Further questions?
I don't know if you, okay.
Steve?
Thanks, Brent, for the report. The SubMisuse Assessments referrals shown from 2014 to 2018 shows a decrease. And I just wonder if you or Virginia or Andrea have any wisdom as to why that's happening, and is it based on economical reasons or a lack of funding or lack of referral of people? But I see a percentage in here that's significant from those years, and I just wonder if you have any comments on that.
I would say in the last few years, like I said before, some of that being the insurance availability that people have, that insurances, managed care are responsible for treatment programming more than they had been in the past. And I don't know if you have a particular thought about why we're seeing some of those decreases.
I would think that's primary, because we've really been pushing that people get on insurance themselves.
Yeah. And so I would say that's probably the primary when we see those changes. And I don't think it's because we're seeing a major decrease in people who are in need of treatment or in need of having an assessment completed. I believe it's more about that insurance piece.
Yeah, Corinne, as you said earlier with the insurance, that was a huge push 10, 15 years ago to get the third-party payer and the third-party recovers, because at that point in time, the curve was going this way.
Yep.
It was a substantial increase, and when insurance companies are now providing that service, somebody pays for it, let's face it, but it isn't directly coming out of the county budget at that point in time. And that was a very significant growth in the 90s and early 2000s, clearly. Further questions? If not, start with the reform, please.
When I wanted to update you, I know in the past I've mentioned some things about reform and where things are at, and I thought that I would update you as to where things are at now and where we're progressing to, where the state of Minnesota is progressing to. Reform has been one of those things that have been in the works and in conversation since probably 2013, 14. In 2017 was the biggest legislative changes that occurred. And what that was is the ability for the Department of Human Services to request at the federal level from CMS the ability for direct access, which is the assessment process, treatment coordination, and peer support programming to be able to be MA billable services. And so that was the biggest changes that happened in 2017. So since 2017, the state has been in this process to be able to sort through how to make that happen. On direct access, what happens now is, first, I think if you look at reform as really being this sense of moving away from it being this episodic sort of situation and moving it to be a very chronic situation, a chronic disease. And so that's some of the concept of the reform is really how do we move away from you're just doing this 45-day assessment or treatment program, how do we continue to look at how do we do a better job at support, a better job at providing some coordination on before as well as after treatment, on what happens and what supports can we give after you've had your primary care treatment programming. So what the current process is if someone needs a Rule 25, as we said, they come to the county, they're required to come to the county, we're required to set those assessments up, get them involved in treatment. We're considered what we call the placing authority, that we are the placing authority and required to get people involved in the treatment programming. And then to follow them during that treatment programming, assure funding in that, and continue to work with providers about the level and the need of funding and to be able to continue their treatment programming. What reform is going to do is it's going to really take the county out of that process. And it's going to move to what is called direct access. And what that means is that if someone is on needing of a chemical use assessment, they're going to have that ability to go directly to the provider, that they don't need to come to the county first. They're going to be able to go directly to the provider. The sense of that is to make it very similar to going to the doctor. If you have diabetes, you're going to go to your primary care, you're going to make a treatment plan, and you're going to move forward with that. Same as mental health. Mental health people who are on medical assistance don't have to come to the county first. They get to go directly to provider, have that assessment, make a treatment plan, and be able to move forward on what their level of treatment may need to be. It's going to be very similar in the substance use, is that direct access is going to allow them to be able to go directly to the provider and to get that assessment, to get recommendations, and then for that provider to assist them in getting into whatever the appropriate treatment programming is. The big change in that now is, of course, is that the providers are going to be able to bill MA for that assessment. It's called a comprehensive assessment. And treatment coordination is another service that's added. And that treatment coordination, like I say, is about how can we follow someone after the primary care and how can we provide supports to them as they move forward. That may be assisting in if they're having housing struggles, for example, or if they need some mental health services as well, and walking alongside them to support them through their sobriety. Those sort of things are some of that treatment coordination, being able to kind of be that broker of service to be able to sort through what are those needs and how can we assist them in getting them to keep moving forward even after they come out of treatment. Peer support, again, is very similar. It's someone who's been through the process, someone who has their own struggles, has been able to go through treatment and has been able to maintain their sobriety, and they're another support that providers are able to connect people to and be able to be that support to move beyond treatment, which is really, I think, in my sense, what I see is the best things that are coming out of reform is that treatment coordination and peer support. And again, providers are going to be able to bill out for treatment coordination as well as the peer support. So what that reform is doing, like I say, it's really taking the county out of the mix of that. They don't have to come to us. Rule 25, as we know it today, is supposed to discontinue by July 1st of 2020. That's if everything goes as planned. Direct access was supposed to already be in place. It's taken a long time for the whole billing process to be able to be worked out, and they're still working on that. So that, kind of in a nutshell, if you will, it is truly about taking the county out of the mix and people being able to have that direct access. One of the challenges that's happening is that I think there was a sense of who is able to do the comprehensive assessment has to be an LADC or an alcohol and drug counselor. It has to be someone who has those credentials. Majority of, I shouldn't say majority, a lot of counties do not have people who qualify for that, have those credentials, who are eligible to be able to do those assessments. And so then the counties need to be making decisions about, are they going to stay in the business of supporting and providing substance use disorder programming or not? And I believe some of the things that DHS probably didn't realize is the lack of the LADC level or the ADC level on people who are credentialed to be able to do those assessments. And so that's a real challenge for rural Minnesota. And because of that, what they're doing is, out of the 2018 legislation, is it was ordered for there to be a study on that and really look at on what effect is that going to have on access. One of the hopes of direct access was that it was going to be able to be more accessible. People were going to be able to have better access. But the workforce is going to be creating an issue with that. And so by the end of the year, they need to be presenting a report to the legislators to be able to look at next session as to see if there can be some changes into the criteria or the qualifications for someone to be able to do the assessment. That may or may not make a difference for us based on what the outcome of that is, and as to what those qualifications would be. We currently don't have anyone on staff, ourselves or corrections, who has the ADC level of qualifications. And so we need to be making some decisions, again, about how do we stay in the business or not. One of the things that we are looking at is the treatment coordination. And how, is that something that we would want to be able to be a provider of or not be a provider of? And as we move forward, there's so many unknowns. Treatment programs, majority of treatment programs are going to provide treatment coordination and peer support. And so the question is, how much business may they be or not be for the county in those situations? And so those are things that we are in ongoing conversation about, and we're almost kind of at a holding pattern right now until direct access kicks in, so we're able to really see what that flow of work may be, and if there is a spot for the county to be able to provide those services. And so we're like I say, we're kind of in this holding pattern. We're continuing to do services as we always have, waiting for the direct access piece to come. Questions on that?
I have, it's going to be hard to reframe this, but recently we did an RFP for the county jail because they were having people sitting in cells waiting for Rule 25 assessments and before they could release them into the general population. And anybody here can correct me if I'm going down the wrong path. So how is this direct access going to solve that? And I also would say we have three vendors that are supposed to be providing this, and then why is there a delay? So that's two questions. I normally don't babble on like this, but I'm confused a little bit.
Yep. I don't, correct me if I'm wrong, maybe, is that I think some of the jail pieces and in the holding cells are really most likely more about mental health than they are necessarily about the chemical use, the substance use.
Rule 40 for ability to stand, are they competent to stand trial?
Right, the Rule 20s, yeah.
All right.
So or that's my understanding, is that some of those holding cell issues are more about the mental health and the chemical dependency.
Okay, that would-
Our providers right now go to the jail, and they do those assessments at the jail, and we have no reason to believe, and from what the providers are saying now, that they won't continue to provide that service. It'll just be that the clients or their attorney or their family, whoever, are going to be making those referrals and working with the provider to get that assessment done. They won't need to come through us to be able to get that assessment done.
Okay,
Does
thank you.
that answer?
Yeah, yes, that helps a lot.
Okay. I think it's been 30 years since there's been any change to the substance use disorder. And so there's going to be a fair amount of bumps along the way here, a fair amount of how does this work and does it make sense or not make sense? And I think it makes sense if it rolls out the way the intent is, and to be able to truly looking at what the needs of the clients are and being able to support them through that sobriety. I think those are the biggest things of reform, I think.
You've said it several times, Corinne, looking at the unknown. This was supposed to be rolled in, a couple of years ago, really, and up to a year now. I would be mainly concerned about the follow-through and the connections. I do know very firsthand of the responsibility and passion that staff has put in to make sure that there is those connections and the coordination and the follow-through and the follow-up. I have lots of reservations about this as to where our position is looking at positive outcomes. Communication results in positive outcomes. So, and I know you well enough that you're also looking at those same types of things as far as the outcomes, because if we have it separated from county management or involvement, is it then the insurance company, the provider, the court system? Who does that? So, but I trust very much, and I know Corinne and your staff are looking at that and asking those questions and more in-depth questions, so that we don't have a catastrophe that will catch us really, really hard down the road when we say, "Oh, gee, I didn't know this."
Yeah. I think some of the, this is my opinion, some of the delay, I believe, is the pushback that has come from counties about, have you thought about the whole picture? And I think that, like I say, I think there's real positives for reform. I think the biggest, to me, like I say, the biggest is that support beyond treatment, that treatment coordination, the peer support. The direct access piece, though, I think there needs to be more of that conversation. And how is that really going to play out in rural Minnesota? And we're lucky in that we have providers in Kansas County. Big Stone, they got to go 60 miles to be able to have a provider who's going to be doing those, would be able to do those assessments for them. And so I think some of this delay may be some of that pushback, and be able to say, do we need to look differently at some of the language and how the language is written, and that capability of assessors who have been, like Virginia, been doing assessments for years and years and years, now to say she's not capable of doing an assessment. And how that's going to play out for rural Minnesota, I think, is an issue that I believe that they're getting a pushback for.
Commissioner Byrd.
Well, I have the same concerns. I have a feeling, and I'm worried that some of these individuals will still show up for the county.
Yep.
And we don't have the resources then, and we can't be prepared to deal with them. I also think we need to, and maybe we're at fault of this too, that we have this county system, that we're not looking at joint powers going across counties more than we are in trying to provide some of those services, maybe up to now, and that could be some of those solutions as well. But I am really concerned about this gap in services and the expertise that the county fills in, that the direct provider you're talking about cannot do and cannot afford to do.
And I think they may be able to afford to do that more just because it's going to be, they're able to bill.
Oh,
Okay,
if
you know what I
there's a bill
mean?
for it.
They're going to be able to bill
If
for
there's a
it.
billable service,
But
yes.
to me, the issue is going to be workforce, continues to be an issue across the board. And I think it is going to be they rely on us to be able to make sure that people are getting into treatment and that sort of thing. That's a piece that they don't do unless it is, it's private insurance or managed care. Because private insurances, managed care still have that responsibility to be that placement authority. And right now, there's going to be more on the providers as far as getting someone into a treatment program, where they relied on us to be able to do that. We have, there's going to be some clients and consumers who are going to continue to need some of that support that maybe is more of that ability to say, okay, wait, now your assessment is this day, and those reminders and some of those sort of things. One of the things that they did with treatment coordination, when treatment coordination started in the process and reform and the conversations, it was about being able to provide that treatment coordination at first phone call, that when somebody called and requested an assessment. Now that has changed, and there has to be a comprehensive assessment that is identifying treatment coordination as a medical necessity, a medical needed service before it's going to be able to be billed out. And so those are those catches that I think are with any change. Like I say, it's been 30 years. So with any change, it's like, have we thought completely through some of this, and how are we going to maybe fix some of those things, that the whole big picture when you look at that, and how when you actually get it into the system and actually get things rolling out, where are we going to see those gaps, and how can those gaps be filled? And is that at a county level? Is that at a provider level? I just think those are still questions that we don't know the answer to, but are completely concerns that we have as well.
Further questions on the reform issue? It has been a positive having our contract ability with the providers. I remember the discussions that we had in developing and working towards that, and there was a little bit of not wanting to increase staff and having the training available, but we are fortunate, and call it even blessed, in this area, as you point out, that other counties that don't have these resources. We are very blessed to have very qualified and very competent individuals and firms that do that, which has greatly expedited over these last years compared to the challenges that we had years ago.
And I think they're providers. So we just had a meeting the other day, excuse me, with the providers and ourselves, just really looking at where's everybody at with reform, and all very open to discuss that, and what are you guys doing, and what are you guys thinking about, and being able to, I think, look at some of that. How do we make sure residents of Candioi County, and of course a lot of them do more than just Candioi County, but how do we make sure clients aren't lost in this, what's making sense, what's not, and I think the providers are in the same boat as us as to how is this really going to play out, and what are we going to be able to provide or not provide, and do or not do.
Thank you to all of you for
Yes.
being here today and for your report. And Jenny, I'll turn it over to you.
Sounds good. So a couple meetings ago, I had mentioned that Charlotte Hand, one of our social service supervisors, has put in for retirement. And today I would like to call forward Amanda Lager. Amanda Lager has accepted the position of our new social service supervisor. She will be overseeing our child protection ongoing unit. So Amanda, if you want to give us a couple words about your background and what has brought you here, that would be great.
Well, I've been with Candioi County for about the past 11 and a half years. I initially got hired in the ongoing child protection unit, worked there for about almost 2 years, and then I moved over to the family assessment and investigation unit and did that pretty much most of my time, and then recently moved to the child care licensing position, which will be almost 2 years in October. And so I'm excited to be back in child protection and looking forward to this new role.
Well, thank you, Amanda, and welcome. We appreciate it.
Thank you.
The courage that you have in assuming into
You're right.
a leadership role, but also the tremendous opportunity to further your leadership and to make commitment as far as child protection. It's a rare individual that says they're excited to be back in child protection.
Yeah.
Seriously. It's a rare individual. So welcome, Amanda, and thank you.
Thank you.
Yeah.
And that's all I had for administrative
you.
updates. Yep.
And we adjourn.